that most of the countries, almost half of the countries, has water scarcity. And water tension is bringing somehow escalating some tensions between different parts of the country, within the country, and between the countries as well. And this escalates the war and the conflict, and this somehow leads to some kind of disaster. So what we are going to discuss in this panel are two things. And the panel has three sections, actually. The first section, the panelists, I will introduce them in a minute. You can imagine that none of them needs introduction. So now we have global leaders and experienced philanthropists, academies, and politicians all together from different parts of the world. And one of us will be joining remotely from Lebanon. And we are discussing two things. The first part is about international background of that. How international law, instruments, tools, health diplomacy, and these things can help to prioritize health. And our panelists will share with you their experiences. Then after 5 minutes intervention by each panelist, we have 20 minutes Q&A. And please, I will come to that. Introduce yourself, identify yourself, and be very concise because we want to use the best of time today. And in the second round, we talk about innovations. How we can actually use innovations in terms of governance, not just technology, governance, service delivery, community engagement, different approaches to health governance, innovative health governance or governance for health can contribute to putting health at the heart of conflict. That's the second part. And in the end, we have a kind of a very brief wrap of 1 minute by each panelist to do that. And I hope, that's the thing, the main message is hope. We are living in a very difficult time. It doesn't matter where we live. We are all concerned about humanity. We are all concerned about the innocent citizens. And we are all concerned why, in this very resource-constrained world, we need to have wars. And war is becoming, in the heart of democracy, as only solution by some countries to continue. So we need to discuss that. But at the end of the day, I hope we will be hopeful that we can do something good for the population, for this innocent citizen at the middle of that by priorities in health. So I am looking forward to the very productive panel. And with this introduction, I would like to ask my first panelist, Right Honorable Helen Clark. Helen doesn't need an introduction. She has been the Prime Minister of New Zealand, and she has had many other hats. That's in the book. But she is more than famous to introduce her. Please welcome Helen Clark.
Well, thank you, Amir, and I think it's really important that this topic is on the agenda for the World Health Summit. And we know we're living at a particularly bleak time at the moment for the impact on healthcare, on patients, on health workers from what is happening. But actually, this current round of heightened level of conflict probably goes back to around 2010 from recollection. I remember when I first went to UNDP in 2009, I used to get these briefing notes from its Bureau of Crisis Prevention and Recovery. And the briefing notes said, the world is currently experiencing fewer conflicts than historically. And suddenly that changed quite dramatically with the incursions, I guess, in the Sahel, which put huge pressure on Mali. There was the so-called Arab Spring, which quickly became a winter, and all the conflicts that arose from that. There was the Boko Haram development in Nigeria, and so it went on. The world started spinning out from around the 2010 period. But as Amir said, it's hard to think of anything that's really captured the most horrific of our imaginations with what's happening with attacks on health systems, health care, health workers, patients today, whether it's the shelling of a maternity ward in Mariupol, the systematic destruction of the health system in Gaza, and this is the only way we can describe it, a systematic destruction. And it's almost as if anything goes. If I say that there's someone that I'm after that's under that building, I'm justified in destroying everything and everybody in it in order to get this person. I mean, as Ban Ki-moon said when the Security Council pronounced on this issue back in 2016, even wars have rules, right? That's what the Geneva Conventions were about. That's what their two protocols are about. It's what the International Criminal Court, with its war crimes jurisdiction, is about. So, the problem is not that we don't have a strong normative framework. We do. We have those conventions. We have an International Criminal Court. We have the Rome Statute. Article 8 of the Rome Statute specifically mentions not turning hospitals, civilian hospitals, into conflict zones. We have Security Council Resolution 2286 of 2016, which demanded an end to impunity and respect for international law. Sad to say, one of so many Security Council resolutions which the Council does absolutely nothing to uphold. So the question to me is how to get member states focused on an end to impunity. Because if we can't look after healthcare facilities, patients in them, and health workers, doctors, nurses, aides, orderlies, cleaners, the lot, what the hell can we look after as humanity? Absolutely nothing. So it's almost an existential human rights issue. Now, there have been suggestions, and I mean, this one tends to be dismissed because there are a number of special rapporteur and representatives appointed, but some have suggested that there should be a Secretary General's special representative on violence against healthcare workers. Rather, as you have the Secretary General's special representative on sexual violence and conflict, or the one on children and conflict. And the advantage of having these special representatives is they can speak truth to power. They can call it out. They can try to mobilise opinion to return to what were the rules of war, where healthcare patients, workers were not targets. And I think we have to think at the global level of how we get member states focused back on their responsibility of upholding the rules of war and the conventions that we have. My last point at this intervention, Amir, would be I really want to commend Dr. Tedros for being a constant voice of the world's conscience on these issues, day in, day out, calling it out, not afraid to call out member states who are responsible for these actions. And we really need those voices at this time, and they need to be supported. Thank you.
Thank you very much, Alan. When we were convening this panel months ago, I was very privileged to have this high-level and high-caliber speakers, each of whom brings a vast experience, not just in terms of academic knowledge, in terms of practice, in terms of being at the high level of politics at the national and global levels. And I'm so pleased to introduce to you, again, this second speaker doesn't need introduction, Mr. El-Haj Assi. He has been involved in many global affairs, and now he's the chair of the Kofi Annan Foundation, to tell us more about what matters in terms of international context when we have the conflict. Mr. Assi, please.
Thank you. Thank you very much. Well, I think the one sentence comes just popping in my mind, when we reflect on these issues, and it's a very simple one. It's not normal. Well, it's not normal that, conflict starts and then we don't know when they end. Who remember even when some of the conflicts we're talking about, and I call it them protracted crises, when did they start? So we are in the middle of conflicts today, and there is no end in sight. That's not normal. And that leads to the fact that, the average time of a situation of refuge today is about 20 years. That's not normal. You can be born in a refugee camp, spend your childhood in a refugee camp, spend your youth in a refugee camp, and become an adult in a refugee camp. That's not normal. So many children, today not being able to celebrate even their 5th birthday. And then we call them many names: children with 0 dose, children with malnutrition. That is not normal. So many mothers, losing life while giving life in those settings. It's definitely not normal. And then overnight in those settings, you see Mr. So-and-so losing everything, including their own identity. They're no longer called Mrs. or Mr. So-and-so, but here they are, the victims, the IDPs, the refugees, the beneficiary of our humanitarian assistance. Well, they lose even what is most important to them and to all of us, which is our human dignity. And everybody who works in a conflict setting and in humanitarian setting, particularly providing what we call humanitarian relief, if you watch closely in the eyes of those so-called beneficiaries, you see a mix of gratitude and shame. That proud father, that proud mother, who used to care for herself, himself, and family, standing lined up 50 degrees in the shade to take home a bag of rice. That is not normal. Well, we also deal with all of this being exacerbated by what we call the shrinking of the humanitarian space. So that nowadays, counting the number of healthcare workers and humanitarian workers who lose their lives on the line of duty is becoming even an indicator of a gravity of a situation. That is becoming now an indicator. And we talk among ourselves, we compare notes. How many Red Cross volunteers did I lose? How many health workers did you lose, Chidi? And then how many other agencies have lost? And this is becoming both an indicators of being on the front line and then serving the people in need. That is not normal. So what we are crying for, and then what people are crying for, when we talk about conflict and then health in war and settings, first thing that we cry for is peace. This world badly needs peace. And it is a total breakdown in leadership, to find peace. I think we can write books, about leadership, write books about diplomacy. But if we're not able to find solution to the problems of people and then find peace, it is a total breakdown. And we are crying for that peace. And that is what the people we serve are crying for, because they cry, for that normalcy. And I think that's really what it's about. Why health there? Because health maybe is an entry point for a certain level of normalcy. Before I talk about even the services that are provided to people, often a time when you ask people, the only thing maybe they share in the situation of multiple deprivations is sometimes, having to go to the same health post. And a moving story sometimes when people tell you how much they're related, they're almost family members. You say, why? Because our children were born in the same health post. And that is, what really health, means to people. It is not in that time when everything is dividing, people. And the fractures, are so profound, that health is not healing the wounds, of the war, but also then healing the relationship, among the people. And that's why it is not by chance when health infrastructures and then health workers are targeted. They are targeted consciously because they know this is what may be bringing some form of normalcy in a situation where they don't want it. So I think what we are talking about here, we face many shocks, many hazards. Those may be natural. The disasters, they come too, and then the conflict that get protracted, these are human. Well, health alone, will be solving it. We become even a risk at it. So there is a call now for partnership. Partnership between sectors, the health workers, and then those, that are waging for peace. For professionals, working on the ground, and then politicians and then diplomats that will have really to create the enabling environment, to have, the necessary conditions, for people not only to survive, which is a very low ambition, but to strive and then recover what is most important to them and to me and to you, which is our human dignity. Thank you very much.
Thank you, Asi. As you know, the lenses of negative peace is having war, and this war somehow leads to the democracy, leads to demolishing the health facilities, the infrastructure, and these kind of things. But beyond that, there is something called positive peace, and that positive peace is about when the war happens, then democracy, the degree of freedom, institutions fall as well. And this is, again, the vicious cycle of war and conflict in which not just people in the forefront are affected because of the consequences in the infrastructure, they are affected because of the achievements of democracy, making institutions and things, which somehow contributes to the less stable situation, which somehow exacerbates the chance of war. And this is the vicious cycle that we are living now. Thanks, Asir, for putting us in that context. Our next speaker comes from Afghanistan, one of the most conflicted areas, and specifically when it comes to refugees that Asi sadly shared some experiences. Afghanistan is among the senders of refugees around the world, and millions of Afghan refugees, because of the prolonged war and conflict, are refugees in other countries. I'm so privileged that Dr. Wahid Majrooh, my close friend and the director of the Afghanistan Center for Health and Peace Studies in Geneva, and the founder and director, and he was the ex-public health minister in Afghanistan by the beginning of Taliban and before that. So he's bringing a national perspective as a high-level politician, as the minister, and now involved in that, to see how the context of Afghanistan has been affected by that. Wahid, please.
Amir put a higher load on my shoulder by explaining that I had the opportunity to serve my people in different contexts, not only before the takeover of Taliban, but as the only politician who stayed in Afghanistan and served Afghans with pride as a privilege beyond the collapse of the Afghan government. So what I can quote today, what I can narrate today, is a story of the complexity of the context in a war and conflict-torn context. Could it be Afghanistan, Sudan, Iraq, Lebanon, and with the troubles, with the challenges that our politicians are making? Unfortunately, could be several other geographies that we are not competent enough to think of today, but unfortunately, it is unfolding. Given my experience, not only in Afghanistan, but in the region, when it comes to the context and the competency and the skills that the global health experts and humanitarian aid workers are equipped with, it is mainly focused, and that's unfortunately rooted in how we are trained as medical doctors or public health experts, what health is, what health facility is, and what vaccine is, what is infectious disease is. But the problem is that by the time you enter a conflict zone, a war-torn community, society, the challenges you face, the needs you hear, and the ones that you're expected to address goes much more beyond you were taught in your chapters, or you have read in the books or research papers that you had access to, especially if you are privileged to come from the Western side of the world. What I've witnessed is that in communities and societies like Afghanistan, which matters is that we have the understanding, the perspective of, in the cultural competence on how to communicate with people, how to get engaged with, how to read them, and how to talk with them. One of the issues that we lesser invest in is to know the language of people. It is not English or Persian or Pashto or Arabic, but how they define pain, how they shape hope, how they ask and thank for the support you provide them. That is something we lack. The geopolitical factors in the political context in which we operate is another aspect that's unfortunately less looked at, and that's why, while in an era where every other role player, especially the politicians, has failed to bring hope, the healthcare workers and humanitarian aid personnel remains the only source of hope. The outcome of our efforts is not meeting the expectation, not due to our intention, not due to the level of our investment or our technical capacity, but our capacity to listen to people the way they were culturally trained in, to analyze and look at that community and society in the conflict that were there to address their health needs from a political perspective as well. The geopolitical factors that are affecting that context and contributing. So with that said, what I want to highlight in this session is that this is a time for us to focus on two issues. First, the capacity of the healthcare workers and the health personnel that goes beyond the health facility. Our politicians has failed to lead the world. Once at the WHO Executive Board, I talked about it, that we need a comprehensive VIP high-level psychological screening of the VIP global leaders. You laugh, but I don't. They laughed at EB. Most of them are unfortunately crying today. It was 2.5 years ago. The outcome of such a sample screening will shock you to see who the crazy people are leading this world. But in every crisis, there is an opportunity, especially for us as healthcare workers. This is the time to take this opportunity and equip our staff members, our institutions, with skills beyond technical topics like vaccine or infectious diseases, to make sure that by the time we step in, we can analyze the situation politically, culturally, while having the geopolitical landscape in perspective, to ensure that the effectiveness and efficiency of our efforts goes beyond our health centers. And that's where we can claim that we value, we invest, and we understand what is called the context. I thank you.
Thank you very much. Empowering healthcare workers themselves, not just with the technical issues, is something we come to that when we talk about the innovative governance in the second part of the panel. But thank you very much, Fahid, for sharing your first-hand experience from the field. Our next speaker, we are too privileged to have two high-level people from the World Health Organization, two pioneer ladies and global leaders who are bringing the perspective of the World Health Organization, which is at the forefront and the heart of many of these conflicts in terms of providing healthcare services and strengthening the capacity of the health system and health system resilience. The first lady who I'm going to invite to the podium is Dr. Saima Wazir. Saima is the Regional Director for Southeast Asia in the World Health Organization, with great experience in running these things in the World Health Organization. So she's bringing the experience of WHO and how actually the context of international help can be facilitated by WHO. Saima, please.
Thank you. Good afternoon, everyone. Before I start talking about what the World Health Organization will do, I'd like to personalize it a little bit. My country of my birth was born out of a lot of violence. And as a child, I heard the stories, I heard the lived experience of young adults and young teenager, of their perspective, their experience of what conflict was, and what they had seen with their own eyes and how it affected. And of course, at one point in my life, we were refugees as well. Didn't have to live in a camp, certainly I cannot tell you that, but being a refugee, it means dissociation from your roots. It means isolation. It means living in fear. It does something. The whole experience of the human network, being disconnected and not knowing if you can go back to your roots, it impacts the family. It impacts the children that they raise, and it is something that is lifelong, having to live through that, and hence why I went into psychology. So, but as far as what we have to do within the health system, we have to have a fundamental shift in how we address that as a health organization, making a shift from just a humanitarian assistance-based approach to a broader health system strengthening. Because in order to survive conflict, in order to survive any kind of crisis situation and still continue to provide health services, the health infrastructure needs to be there. And this is a lesson that we learned the hard way during COVID. Every country, every area that suffered the most is because they did not have a robust health infrastructure. Using the Foundation for Universal Health Coverage, WHO recommends reorienting health system using a primary health care approach. This also has the effect of building health systems which can better withstand war and conflict and provide much needed services during times of crisis. Of course, as was mentioned, the crisis that is going on currently in the Middle East means our health systems, in fact, are attacked. In 2023, WHO reported 1,300 attacks on healthcare in 19 countries. We'd like to see the statistics in 6 months. Facing humanitarian crisis resulting in over 700 deaths and more than 1,100 injuries among health workers and patients. In our region, the volatile situation in Myanmar has led to such attacks on infrastructure and workers. The world has stopped talking about this protracted crisis, but we really need to discuss that further. We need to protect healthcare infrastructure and those who work in there, in conflict-affected areas. This is of paramount importance to ensure healthcare services are provided uninterrupted to all beneficiaries. We need to strengthen local systems by training healthcare workers and improving the infrastructure in order to enhance service delivery in areas of conflict and in times of conflict. It is vital to systematically integrate mental health and psychosocial support, as well as assessing our leaders, into the essential healthcare services being delivered and into existing the primary care platforms. And I keep reiterating primary care because that is an area that has been neglected and shortchanged. The mental health fallout of war is immense, and building better psychosocial support systems for normal times helps us provide that same support during times of conflict. Systematizing health information and surveillance data in fragile, conflict, and vulnerable settings is also important. Addressing the challenges in conflict areas requires a multifaceted approach that focuses on data-driven decision-making and the holistic understanding of health. I'll be speaking a bit later about WHO's Global Health for Peace initiative, but it is also relevant to our discussion now. The GHPI aims to strengthen or improve the role of WHO and the health sector as contributors to improving the prospects for peace. For example, by implementing health programs with increased conflict sensitivity and, where appropriate, contributing to strengthening dialogue, social cohesion, or resilience to violence. The ultimate objective in doing so is to better protect the health of populations, especially in fragile, conflict-affected, and vulnerable settings. At global policy level, the GHPI is also WHO's contribution to the UN Sustaining Peace Resolutions, which ask all parts of our UN family to use as influence for mediation, conflict prevention, and conflict resolution. In conclusion, let me say something which might sound obvious but bears repeating often. The best way we can prioritize and protect health is by stopping war and conflict. And all of us, from whatever our portfolios, maybe we can understand that whatever we can encourage for the cessation of hostilities in our countries and our regions, it's also our priority. So there can never be, as Dr. Tedros says, there cannot be health without peace, and there cannot be peace without health. And as much as we want to focus on that, we also need to focus on ensuring that we take care of our health workers. Thank you.
Thank you, Dr. Saima. If I can have Dr. Shadi Saleh on the screen. Our next speaker is the testimony of that we are living in the middle of war and conflict. Professor Shadi Saleh from American University of Beirut is a founding director of the Global Health Institute. And months in advance, we planned for this, and he was supposed to be here, but he couldn't come because of the war. And this is the situation there. And he's bringing with him the rich history of being as a country who has been within the war in the last few decades, and now is at the forefront of that, and how Lebanon is responding to that, and the context of that is very important to share. So, Shadi, thank you very much for accepting to be with us in this difficult situation, and floor is yours, please.
Thank you, Amir. Can you hear me?
I hear you very well.
Perfect. Thank you so much. I want to start off by thanking Amir for facilitating this. When we first started discussion on this session, I didn't think that true to the title of the session, which is Health in War and Conflict, that I will not be able to make it to Berlin. But with the blessings of technology, I'm happy to be with you all. Actually, for most of you, the Middle East and North Africa region is basically an epicenter of humanitarian crisis. It has been the case for many, many decades. And the question is, will this stop? Probably not in our lifetimes, but miracles do happen. So the question is, in the context of our discussion, is the issue of what do we do with government when this happens? So just a very brief overview that, as Hanan said, the protection of sort of the international community of health in general, and also health workers and health facilities, started all the way from the Geneva Convention, 1846, updated in the 1900s. But basically, the most two prominent sort of piece of international regulations are, one, the human rights law, which applies in all times, and IHL, which is the international humanitarian law that applies specifically in the context of conflicts. So the question then becomes, what can be done in an international settings where basically entities or countries that start wars are actively engaged in wars? What happens when these countries do not abide by neither the human rights law or the international humanitarian law? As far as practically we can see, is that the role of many of the international agencies is basically counting injuries and counting deaths and so on and so forth. However, what has been quite impressive from an institutional, global institutional standpoint is that over the past, I would say, maybe 2 to 3 years, we have seen that both the WHO and the UN in general have been quite vocal about this. Specifically, Tedros, who has been a very active advocate for protecting healthcare in conflict, and also lately, or it has been visible lately, with Secretary General Guterres, who has expressed opinions that have put him as a persona non grata in some of the countries. So basically, this is sort of the formal international governance applications of what can be done. But the question to us, all of us, and we'd be interested to hear from you in the Q&A section, is what can we do as a global health community? So in my mind, it's 3 things. The first is we have a moral and a human obligation as a global health community to have our voices heard when it comes to healthcare workers, healthcare professionals, healthcare facilities. Because my friends and colleagues, what is happening is that when you militarize, whatever country, when it militarizes healthcare workers, then targeting them becomes easy. And it's our responsibility, collective responsibility, as a global health community to counter that argument. I'm not saying that this will have a real effect, because we as a global health community have been quite vocal in the past few years against attacks on healthcare facilities. However, believe it or not, and we're seeing this in recent years, that if for nothing, then our contribution and what we are saying is having an effect on the collective memory of humanity. In any part of the world, if you ask a young woman or man now, in any part of the world, in any conflict of the world, it is quite clear in their head who is the aggressor in terms of healthcare, on healthcare workers and healthcare facilities. So I would say that we have that collective responsibility to keep pushing that, definitely to support and all of the efforts that are done by WHO, by the UN, and perhaps do some lobbying and advocacy that it goes beyond just the counting of numbers to an active advocacy and lobbying. And I want to add to what Wahid has said. I think it's not enough for us to measure sort of the mental status of global leaders. I think that we have to take it a step forward, which is any elected or non-elected head of a nation should review and sit for an exam when it comes to international humanitarian law.
Thank you, Shadi. Thank you. In addition to other exams that the leaders should take.
Let's start, as a global health community, let's start with at least them understanding what international humanitarian law is, because even if morality doesn't help them with that, at least they will have a knowledge when they cross that line.
Thank you.
Thank you.
Thank you very much, Shadi. And last but not least in this round, I'm so pleased to invite Dr. Matsudido Rebecca Moeti. She is the very experienced Regional Director of Africa from the World Health Organization. She has been so kind to travel to Berlin, and we are keen to listen to her experiences, how in the context of Africa, the international context and the World Health Organization is doing to prioritize health in war and conflict. Dr. Moeti, please.
Thank you. Thank you very much for that kind introduction, and thank you for having enabled me, representing my colleagues in the African region, to be part of this very important conversation. I think I'd like to first thank those who have made reference to our leader, Dr. Tedros, for his courage and for having started an initiative that my colleague from Sierra mentioned that I will speak about in the African region in terms of what has been the experience then in rolling out these efforts to make the connection between health and peace in some of the countries. I think I can only add my own voice to the observations that have been made and the concerns that have been expressed about conflicts and their impact on health, particularly health service delivery, health workers, health infrastructure, and the apparent sliding of some of the principles in terms of what is being seen today, which is so vividly and dramatically being illustrated in the one example that we're talking about in the Middle East, in Gaza. For me, as somebody who's worked in health for many years, admittedly in HIV, but also as a regional director, being more aware of conflicts and health, it's been truly shocking to observe. So it's just to express all our sympathy for the people that we see on the screen running back and forth every day in ways that are truly heartbreaking to observe. There's been some mention already of the principles and the laws that govern this work, particularly issues around the protection of civilians and medical personnel, which we see being more and more frequently violated, attacks on healthcare facilities, indiscriminate violence, and denial of humanitarian access, which severely hinder access to essential health services to people. And we know disproportionately affect women and children who are living in conflict areas because they're the ones who are the least able to take action to protect themselves. So I'm interested in really elaborating on what we are observing in the African region on this global initiative that has already been referred to, that was started by Dr. Tedros, the Global Health and Peace Initiative. And just to say that I have a very fond memory of the ambassador of the Central African Republic in Geneva, who was one of the leaders, who was one of the people who discussed the situation in his country with Dr. Tedros, which was part of the evolution of this idea, and who traveled to his country to mobilize his head of state. And I'll be talking about the Central African Republic as a particular example of action that's taking place at all levels to build on health as a bridge for peace and to make real and concrete some of these principles that we are discussing here today. We know that there are many, many discussions about equity today. The COVID-19 pandemic heightened our awareness of equity, something that's been a problem and a challenge for global health for many decades. But I think coming out of that awareness, we really need to pull this back to issues of conflict and health and analyze and understand how the idea of equity is an absurdity in situations where we see these violations of these laws to such a degree. And again, remind ourselves that women and children are the groups that are the least able to have equitable access to services in these situations. So what is it that we have observed in this initiative on health and peace in the African region? There are a couple of examples where we have seen political leaders as well as health ministers, as well as communities at different levels, be engaged in such a way that it makes a big difference on a continent where we've been very concerned to see conflict spread. As we were hoping that peace was taking root, development was advancing in the region, we've seen the Sahel countries, we've seen a whole swath of countries from west to east be affected by conflicts. We're seeing changes of a political nature taking place on the continent that unfortunately also involve conflict. And we've seen really, as somebody was saying, as us was saying, protracted conflicts that we almost forget about. We forget that there are children who have grown up, multi-generational families in Kenya, in refugee camps in Kenya, connected to the conflict in Somalia, in that region where conflicts are going on all the time. And we're seeing I come from South Africa, and we're observing from Southern Africa the situation in Mozambique, for example, draw down to that level, that part of the continent. And we're really wondering what part of our continent is going to be free of conflict. So these conversations about health access, health as a human right in these contexts are more and more important. But just coming back to the examples that are part of the global initiative that WHO is promoting. We had a formal WHO resolution, a World Health Assembly resolution to adopt this strategy. So we can say to every single country in the world now that your Minister of Health, the leadership in health, sat in a room in WHO and adopted this as a strategy and follow up to see how this is being implemented, respected as an agreement at the global level by political leaders. Because I dare say that the ministers, when they adopt resolutions, adopt them on behalf of the governments right up to the heads of state in their countries. So our expectation is that these principles will be implemented and respected from the top political levels right down, as I say, to communities. We've seen a very interesting example, as I said, has been the Central African Republic, where the political commitment to health and peace goes right up to the head of state, where the Minister of Health has adopted this as a central part of health development in that country, and where we have seen engagement of community leaders. So it's not only something that's discussed in the offices in Bangui, but it really is the minister and his partners, WHO very much involved, other humanitarian actors involved, going out into the conflict areas and engaging community leaders and people so that we have processes where people from warring factions sit down together and agree what is it that they are going to enable to happen so that people can have access to healthcare. And I was privileged on a visit to the Central African Republic to take part in one such a meeting, really with a range of representatives of communities where the key emphasis was that health is a value that we all share, whether we are factions at war with each other. And if we recognize that common objective on behalf of the people that we represent and the people of our country, we can sit together and agree that we are going to do this, we are going to enable healthcare to occur, and we are going to declare certain times where we lay down our arms and we enable healthcare workers with the support of international partners to come in and provide healthcare. And the hope is that this can become a regular way of valuing health as an entry point to then talking about how to expand this to actually talk about peace and create the environment in which healthcare can enable other aspects. And when I was in that conversation, I was asking, so what happens about education? It is very important. What happens about schools? We need to be thinking about that as well, because we know that education is inextricably linked to health, to improving health. But just to say that we've been able to use such approaches not only in the Central African Republic to work with the healthcare workers who are there, because we know that when there is conflict, the specialized, very trained healthcare workers, of course, find safer places to work, but working with local people, training them to have the essential skills to be able to reduce maternal deaths in that area. And it's something that we've used as well in the eastern part of the Democratic Republic of the Congo, in other high conflict areas, to be able to come in and use health as a way of promoting peace while at the same time improving access to health services. And we're very hopeful. As just said, I'm the transitioning regional director of WHO. In 4 months' time, I'll be going back to my country, and somebody else will be taking over. But I'm quite confident that this is something that's going to continue to expand in that expanding range of conflict areas, which is very concerning on the African continent, and contribute to this global movement on this. Thank you very much.
You. Thank you very much, my fellow panelists, for this very insightful discussions. We're a little bit behind the schedule, but I will ask my panelists to somehow shorten the second part of the intervention so we can have more Q&A. So if anyone has any question, comments, please identify yourself. There are some mics, and then we very briefly and address to whom you have a question, and try to keep it maximum 30 seconds so we can move around this. Okay, 30-second max, please. because we do want to enjoy from all the different audiences. This gentleman in the middle with the glasses, yes?
Hello. I think 30 seconds, I'll just say my name. My respect, I'm Rawand Kamran from Kurdistan region of Iraq. So now we have Afghanistan, we have Iran, and we have Iraq also. So I would just like to tell you the different aspect of thinking from, rather than blaming one person, according to my experience since 10 years being a clinician and dealing with the decision makers, I think the priority for the politicians in our country is not health. So the health is the last thing. Like, for example, when they are candidate for the parliament or candidate for the government, there's no competency on health. The last thing is health. And the question is, instead of blaming that one person is the cause, I'm saying that the community and the primary health care and the health system in that country didn't distribute to the community, to the society, for each person, even our kids, my parents, my relatives. I have to give them the explanation. I have always to give the lectures. Okay, your health is the priority. So I think if from today the new generation works on health on themselves, then in future, after 10 years, the guy who becomes a prime minister or who becomes the minister of health, he will think differently that health is the priority. So we have to work from below up. Thank you.
So prioritizing health for the citizens from the very earliest stage with early child development. This lady here, yes, please.
There's Sindat Evren from Germany-based network of Kurdish academics. I was just to mention the prison conditions in especially countries of war, but also in other countries. For example, isolation of prisoners is a huge problem in many countries. Turkey is just one example. For example, we have the prison island of İmralı, where PKK leader Abdullah Öcalan is imprisoned. And now this isolation or incommunicado detention is also a practice in all other prisons of Turkey, especially in regard to the political prisoners. So I think when we talk about health in war and conflict, we have also to focus on the prisons.
Thank you. Any comments on that? We take some more comments and comments. Yes, this lady on the second row. Yes. I think this mic is better.
This is better. Thank you very much, Catherine Urbais from the Health Diplomacy Alliance. I go a little bit back on the leadership and the essential. I mean, it's not normal what is happening. We have had conflict, but what is happening is really not normal. So health diplomacy has been the mean to bring health to those situations. Do we see health diplomacy is still at the mean to ensure that we have something as essential as having health in this disrupted scenario?
Thank you. So health diplomacy. I think Helen, Essie, and others can take more questions. This gentleman, yes, please.
Hello, my name is Uwe Schneider. I'm the director for disaster and conflict medicine at Lecturium. We are currently training 15,000 healthcare professionals in Ukraine and a couple of 100,000 people from civil society in disaster medicine via online learning. Because what we have done, we have 12,000 videos in medical education with Ivy League and 200 other universities in operating nearly 80 countries. And what we learned is if there's a supernatural conflict, the healthcare system will collapse, will be overstretched. So we see that in Ukraine, 1/3 of the healthcare professionals left the country. 1/3 is in the front line, and 1/3 should really serve the rest of the country in public health. So I would advise to build a working group, a council at the WHO, to discuss such scenarios, because we are talking about universal health coverage. We are talking about to train community health worker and everything like this. But if there is really a conflict that is supranational, then the systems will collapse, and we are all not prepared. Also, Germany is not prepared to serve 5,000 casualties per day outside the military hospital system. And that is what I'd like to get out of this summit here, that we are getting our heads together to make guidelines on that, because this is very important. Thank you.
Thank you very much. This gentleman on the third row, please. Yeah.
Okay, thank you very much. I'm Ababa. I came from Ethiopia. I'm MSI country director. I think this subject is really pertinent and is very relevant where I came from. And my point here is, apart from just holding in leaders and accountable and just making sure that they have to pave the way, how can we build the capacity of civic societies and at the same time professional associations, because these associations, civic societies, there to raise the voice of for their constitution or for their community. So sometimes the voice of civic societies and professional associations are not as such heard because of they have not able to do that. So might be one of the areas which I'm like to comment is how, or just ask, how can we build the capacity of civic societies, and particularly when it comes to healthcare professionals. There are dedicated professional organizations, because their presence is just there to support their membership. So how can you build and how can you use them as a vein to influence the local leaders in order to bring such kind of things on them?
Very important question. Thank you. This gentleman in the middle row. We take 2-3 further questions and then, yes,
Hi.
please.
So I'm Deputy Director for European International Affairs of the French Ministry of Health. We talk about the importance of training healthcare workers. It's very important, and I believe that the academy, the WHO Academy, that will open its door in December, can play a key role also in this field for work situation and so on. But I wanted to say also, it's not only about training healthcare workers, it's about training people that will become the healthcare workers tomorrow. And we should think about the refugees also in the camp to develop nurses training for building the future healthcare workers they will need, because their system has collapsed. This is something we should bear in mind. The best thing we could do this is to empower the refugees for the future in the health management, health system forces they will need. Thank you.
Reaching out the refugee trainees themselves. Yes, this gentleman with the white shirt. Yeah.
Hello. So my question is,
please introduce yourself.
Oh yeah, I'm Sami from the WHO here in Berlin, the hub. I have a very simple question. So many of you mentioned that health can be used as an entry point for peace. I'm wondering to what extent it could be like an engine for peace, especially in like protracted conflicts where the health system has been so eroded that they are maybe even dependent on outside help. So how can it be an engine for peace and not just an entry point?
Thank you. And this lady here, the last question, this place.
It's a question and a comment. Esperanza Martinez, Head of Health and Human Security at the Australian National University, and as Head of Health of the ICRC at the very inception of the conversations about health and peace at WHO. I really find that conversation very, very dangerous in the current environment, in the sense that, yes, it's true that bringing actors together to talk about access to healthcare could be promoting bridges to peace, but the outcome should be access to healthcare. As today, a Russian and a Ukrainian, how peace is defined, and you will get two different answers. As a Palestinian and an Israeli, how peace is defined, and they will not sit around a table to discuss peace. But ask them to sit to discuss health outcomes as a human right and a right for all, and that will be something they will be amenable to do. So I think that we really need to be very careful about how this is understood. I know that within WHO is very well understood, but globally is not very well understood. So health, we should all pursue the access to health and the protection to healthcare because it's enshrined in law, but we should be very aware of how it is perceived when healthcare workers use that platform to start to discuss peace, because peace is a very political concept and could really backfire on the protection of healthcare. Thank you.
Thank you very much. Wonderful questions. I will ask the panelists to reflect very briefly before, because many of these questions you mentioned in the second round where we are discussing about the innovations in the governance and the service delivery. This will be covered, I promise. But if there is any quick reflections, any of you panelists, and Shadi, on the questions, it was something about health diplomacy, how it can contribute to that. Health as the mean to peace as well, training the healthcare professionals and the trainees in refugees camp, and then holding leaders accountable, the capacity of the leaders and the people, these kind of things. Any? Ashley, please. It's on.
Yeah, thank you. On the civil society and communities, well, that's where it always starts, and that's where it always ends. any health problem start in communities. If we had to solve it, it can happen there. And the reason why then civil society and communities are important is that they're there before conflicts, they're there during conflicts, and they're thereafter. And that is that continuum, that matters, most of the time. We change for the better a little bit, so in the UN. So even in my own professional life, when I was starting working with the UN, the regulation was that whenever the bullets start flying, we go. So we leave. So then I think over time we had a discussion. It's not about when to leave, it's about how to stay. And that is critical. Many a times, communities accept us because people think that we've done miracles. But they put it in simple ways. We trust you, we can work with you because you never left us. And that is, so critical. And I think we can do that only when we work together with the communities, with civil society organizations, and empowering them. What my colleague from ICRC said is extremely important. And I think we're not telling healthcare workers to discuss peace or to talk about peace. But through their action, it is simply the mere action of health intervention, is contributing to building social capital, is contributing, to also building peace among people, whom everything else, divides. So I ask first, an Israeli from Magen David Adom, which is the Red Cross, of Israel. When you are in the fields and then you see on the scene a wounded Palestinian and a wounded Israeli, who do you care for? He said, whoever is in greatest need, was his answer. And I think these are the kind of actions, that contribute to peace, rather than healthcare workers coming and discussing it and then try to do it and so on. And I think we can see that in many, many, other examples. So health diplomacy, yes, I think we need, more of that, honestly. We need more of that in training. We need more of that, in equipping, diplomats, to take into account, the health issues. We need also to equip, health workers in certain settings where they don't have any other choice, but you negotiate passage, you negotiate, humanitarian space, you negotiate, even if it is, how do you call it in English, une trêve, a pause, to vaccinate children, to do all of, look, in Gaza, in the middle of, it's almost crazy, it is surreal. Regardless, we have to negotiate to vaccinate polio, against polio. Well, fine for the kids, that are being vaccinated against polio. The cynical will say, what's the point to vaccinate them against polio and then bomb them the next day? But nonetheless, this is what maybe health and healthcare workers, do in the middle of something which is totally nonsensical, in a certain way. So I think you could cite, examples of Somalia. You could cite, example of DRC. You can cite many of those, places where we had, to do, that kind of a work. And who was that? You mentioned mental health. In conflicts, of course, we think first trauma. We care for the wounded. We bury the death. And that's what we usually do when we're there on the scene. But so many people living with those invisible wounds over a period of time, that has come as an afterthought. To bring that right from the start, as a priority, is also a contribution to peace. Because, people may be in a state where they will not always think revenge. They will not always live with the grief. And then, this kind of a anger, that will then perpetuate, this cycle, that we're talking about.
Thank you, Essie. Wonderful. For the sake of time, I would ask the panelists to reflect upon any points in the second interventions, and we need to shorten the second intervention to 3 minutes. And I would like to start with Essie again. If there are, you're done? Okay, thank you very much. So we save time. And then I go to Saima, and you can sit and you can do interventions from there. So what are the innovative approaches that you can recommend to reach this situation that we discussed, please?
Well, certainly one of the big innovations, and one thing that you touched on, is we have to incorporate mental health and mental health support for those who are health care workers of frontline, in the front line, as well as people who have survived. We've taken care of a lot of health issues, but we completely forget the impact mental health will have, and that will continue and be ongoing if we haven't addressed it right from the beginning. As far as one of the innovative ways, resource mobilization, ensuring that we have funds. In Southeast Asia, we have a Southeast Asia Regional Health Emergency Fund that was created. It's an operational fund that we established that member countries have recently also increased. It's expanded how it can be used. Now it can be used in order to plan and prepare, as well as when emergency situations are occurring. So since its inception in 2008, CRF has aided 10 of our 11 member states, facilitating 49 emergency operations and total disbursements of more than 8 million. Recently, it started, and its real use started with during COVID-19 pandemic, with the scope of the fund, expanding it so that we're using it from the planning time onwards. I'm trying to, one of our pivotal steps has been the health cluster localization strategy. It started in June 2024. Provides a practical and holistic approach to ensure meaningful engagement of local and national actors in the health cluster as a coordination mechanism at the country level, and so that we can also coordinate at the country level but with the global health cluster. Tailoring health policies and programs and interventions to the specific needs of the population, being sensitive to the culture, to the realities, to the languages that they speak, because we kind of tend to talk languages within countries, but even countries have communities that have a lot of different dialects that are almost literally different languages. So ensuring that we're sensitive to that, sensitive to the religious and social identities of people, because if we want to provide health, we are working directly with families. So we have to be very sensitive to what their belief systems are, what their approaches are. Using a multidisciplinary and multisectoral approach. So during any kind of crisis situation, there's multiple actors that are involved, and ensuring that from the planning stage, the health system workers are they're part of that planning. And this is many of our countries that has worked very well, that is able to address health issues, but they're right there from when the planning is being done. Collaborating with community volunteers, ensuring that there's representation by vulnerable groups and marginalized groups, because they may tend to be a bit more isolated, and so ensuring that their representation is there, and that people in the communities are also where this is support that they're going to get. And so there's a little bit of more engagement and ownership on both sides. I mean, health systems we kind of have this belief that we're supposed to provide that healthcare, but the recipients also need to be involved. They need to know what is going to be there, and then they'll be able to be part of the care that we provide. Many of our countries in Southeast Asia certainly have that already being enacted, and I think it's important that we look at how those are working, how effectively they're working, and use that as a model in other areas and regions that it's not there.
Thank you. Thank you very much, Saima. In terms of health system strengthening, and I mean, being a psychologist, she mentioned very beautifully how it is important to strengthen the healthcare workers in their own capacity, in their own languages, and reaching out the community. So this is exactly what we need when we talk about the new models of health governance or governance for health. It's not necessarily about the government. It's about empowering the societies, empowering people, and those empowered people can make people accountable, which is very important. Vahid, could you share the experience of Afghanistan, if you have any examples that you have done for innovative ways of governance?
There are several examples, but what I want to highlight today is the role that our community health workers played. And the reason I focus on that example is to present a vivid example of the resilience of Afghan women and girls. As the only women and girls around the world who are systematically deprived today from access to education and work. But that part of my society was, are, and will be the main bridge between the government from the health sector and the communities. In Afghanistan, where we incorporated the CHWs within the primary health care system, they are recruited from local communities. The least investment is required, but the amount of the return on investment as a result of their commitment, the understanding of their societies, their culture, the context, and I agree with the lady which talked about how sensitive it is for a healthcare worker with a good intention to advocate for peace and then unintentionally creating a challenge. And that's where the Afghan community health workers, who were in several instances the only signs of government's presence in remote areas for years and decades, who are the real champions of declining the maternal mortality rates in sustaining health service delivery in the peak of conflict, were not only the healers of physical pains, but the communicators of peace. And that's where the significance of cultural competence in the social wisdom comes in. The problem is not how it is communicated when it comes to peace, but the problem lies when we look at complex, multidimensional topics like peace from a technical and unidimensional perspective. And that's where only providing a workshop on a specific topic of leadership in health or health diplomacy, there are some very good fashionable words today coming into global health. Yeah, and that's not something that will create wise institutions and health advocates. That will create further mistakes and misunderstandings. In my context, in Afghanistan, our community health workers remained in their societies, as rightly said by Asi. They were the bridge for communication in health service delivery. They became examples of hope, resilience, dedication, and an example of the capacity of communities at all, and women and girls, in a society where gender-based violence has been prominent, unfortunately. So with that said, what I want to highlight is that innovation in health does not only always means to bring AI technology in a village, or a high-tech CT scan machine or MRI in a health system. But it depends on how you understand the problem, as I said, the definition of the problem, and how strategically your investment is oriented to make sure that the return on investment is not only the health, but beyond that. Because when my community health workers were working in remote areas at midnight, serving their people, they had the knowledge, the capacity in the network not to analyze the pain. The lady was suffering, but the socio-cultural and political environment where she was stuck in and how she could help her being referred to another health facility. That is the complexity and the comprehensiveness that we need in our global health curricula. Thank you.
Thank you very much, Fahid. And thank you. Dr. Mashidiso, could you bring the context of Africa in some of those very good examples of innovation, please?
Thank you. I mean, I think just following up on the comment that was made by the colleague and going forward, these examples that are there perforce in some of the countries in the field where it's the people who are locally available who provide the healthcare. I think one of the things that needs to happen now is how to recognize that, how to recognize it formally in the system so that it doesn't become the second class, whatever is available, so that there's an intentional investment in this and an intentional recognition in this, of this. And so that they become part of the strategy that's recognized in the financing that's going to be provided, in the dialogue with the professional bodies that still think they govern how healthcare is provided when in fact they're absent and healthcare has been, and in Africa this has been happening for many years in some conflict situations, but it's something that we've called task shifting, that is voluntarism, and people can be volunteering their time, gaining skills, looking after the health of their neighbors for years. And that needs recognition, that needs building on those skills, that needs then to be a formal part of the way healthcare is provided, recognized by the government, supported by international bodies, so that it is capacitated in the way that it deserves. And I mean, just briefly to say, when I was talking to the UN team in the Central African Republic, and we were talking about this conflict area, which is quite a large proportion of the country, I asked, so what is our investment in health about in those areas then? The doctors have left, the community workers are providing healthcare. Are we recognizing that we need to invest there? We can't be bringing people in from outside, international workers who stay for 3 months, 6 months, a year, and go away. We need to recognize that the healthcare provision is by these neighbors, these mothers, as you said, these women mostly, who don't want to leave there because their families and lives are there. And then the investment needs to really be there for local people in addition to international providers who come in and out.
Thank you very much, Dr. Multi. And Shadi, Lebanon is a specific context. The country has almost the same population of its own citizens as refugees. It has been facing this. So could you tell us more about those innovative approaches, given the fact that, because we are close friends, I'm going to ask you to be shorter than others. Because I'm getting notes that there are 10 minutes to finish. Please.
That is what one benefits from friends. So Amir, I'm going to be very, very brief. And I'm going to say, first, a very important observation to note that when healthcare workers leave any area of conflict, the level of trust or the indication of escalation in this area for the people goes up. So when ICRC leaves, when MSF leaves, when a hospital is hit, the people and unconsciously feel that the worst is yet to come. So I don't want to talk about Lebanon in general. I'm going to address your point on innovations. And I'm going to be sort of a little bit blunt. And I think this applies everywhere. There's no context whether it's in Africa and the Middle East, in Ukraine, in Russia, or whatever. So I will propose 3 things. The first is that the global health community, this is the first, the global health community, including civil society, should be part of the formal governance structure of UN and World Health Organization. Because time has shown that these entities, we, the global health community, the civil society organization, have the courage to be quite vocal and less diplomatic, and this is what is needed in these situations. So this is one. My second recommendation or innovation is, as I mentioned before, they have to be a compulsory training of national leaders on international humanitarian law before they can attend any international meeting. So they get elected today, and if the meeting is in 2 months, they should finish that training before that. So this is second. Third, and this is going to be a little bit extreme, but these times require extreme measures. Third, establish a tribunal for crimes against healthcare workers and facilities, and classify that if found guilty at the level of war crimes. So basically, any nation or group that is found to attack healthcare facilities, if they convicted, this is a war crime. So 3 things. I think these times require drastic measures, being diplomatic and going back into the sort of diplomatic language of UN organizations, including sometimes WHO, would not fit the times that we're living in. Back to you.
Helen, who better than you can put it in the picture? Asi was in the session this morning. I really enjoyed, and this in the health policy lab, he was talking about the fragmentation that we have and the organization of the healthcare, different donors and things. We live in a very fragile world in terms of providing financial resources, governance, and everything. And at the same time, we are facing one of the worst recent history experiences in terms of humanity, wars, and conflict. With your vast experiences as the politician, as the prime minister, at the head of the international organizations, your vast engagement, putting all things together, what are your main recommendations for innovative governance which are feasible to move forward, please?
Well, I think my main takeaways from this discussion, firstly, would be to say that Shadi's last suggestion is not an extreme one. There should not be impunity for the war crimes being committed through the attacks on healthcare facilities, health workers, and patients. And the suggestion of a special tribunal is not a stupid suggestion. It's quite a good one. The International Criminal Court, of course, has a jurisdiction to try war crimes. It can only ever do quite a small number, go after the ringleaders. But the idea of a special tribunal is, in my opinion, quite a good idea, which should be thought about. Secondly, I think that we need to know more about the Global Health and Peace Initiative of WHO, because I've done a little bit of quick research while we've been sitting here, and it's quite a sophisticated initiative and approach that's being rolled out here to say that health systems and delivery have to be very conflict sensitive. Otherwise, they may do unintentional harm in the context. And they really do emphasize that community engagement in the design and delivery of services. So I think it would be fantastic to hear more about this, hear more about the Central Africa type examples, and hear about how the world, the donor community, the multilaterals, other multilaterals can support a very important initiative. The third point building on that is you have to invest in the local actors because, as has been said in another context, they're there before the conflict, they're there during the conflict, they're going to be there after the conflict. They have to be empowered. They're going to be the ones that stick around, that the people will have the trust in. And then a final point I'd like to register is that often with crises, we focus a lot on the refugees, the people who've gone over the borders, but there are always a lot of internally displaced persons, and it's often very hard to deliver to them, let alone to the population that isn't displaced but is under siege. I recall when the conflict in Syria was at its height, and there was I would go to donor conferences, advocating on behalf of UNDP, and everyone was focused on how do we support the refugees. And you'd say, excuse me, there's 30 million there who haven't been able to leave. And it may not be the most popular cause to raise money for Syria, right? But there are people there in dire need. So getting a focus on those who can't leave, only a very small proportion can leave, usually. So Yeah, I think we need some more straight talking in the governance bodies that talk about these things. And I really hope the governing body of WHO is very supportive of what it's trying to do with the Health and Peace Initiative, because I think it's on to something.
Thank you. We have almost 3 minutes, and I want to be very provocative and ask each panelist to give 2-sentence maximum, the takeaway message, and then I wrap up. Simon, please. Ladies first.
Mental health. Ensure that we have psychosocial support.
Thank you. Asi, please.
Be there before, during, and after.
Great, thank you. What's the addition? Please.
There's no primary health care in conflict settings. So we need to invest in that.
In PhD, thank you. Vahid.
A call for a paradigm shift in global health curricula. And the second, I do not agree. Health is not politics or a political topic. It is, we have to be ready to address it with our health agenda.
Thank you. Shadi.
So I would say we should believe in the power of the global health community to be a very strong advocate for peace and health.
Thank you. And Helen?
No impunity for the war criminals who are carrying out these crimes.
Thank you very much. We discussed many things. I don't want to repeat. What I want to say is what Helen mentioned is about the initiative, the Health and Peace Initiative by the World Health Organization, ratified by WHO 2019, which uses peace as health as a means of peace, aligning with Global Health Initiative. I think this has a big capacity, and we need to build up on that, and we need to somehow go to our policymakers, to our communities, and work on that. And at the heart of that is partnership and collaboration. And some thoughts for the future. I have summarized 5 pillars. Which I think are important based on the discussions and your reflections. Strategies for effective health governance to put health at the priority during the war and conflict. The first thing is strengthening local health system resilience, strengthening local language, talking to people and going to them and somehow equipping them, not just with technology, is something which matters. The second thing is community engagement. We need to empower people. We need to create a kind of enabling environment for people to prosper, and those enabled people can make the politicians accountable. The third one is innovative solutions. We have had mobile health, telehealth, and these kind of things, but these are the part of the solution, but not just the solution, not just the new technologies can solve the problem. The fourth one is policy advocacy. We had lots of calls about how we can actually make policymakers trained and providing with somehow testing them, making sure that they are capable enough or they are mentally and physically good in doing this kind of initiatives. And last but not least is capacity building. Capacity building matters. Training, education, advocacy, working together, and at the heart of that, collaboration and partnership. This World Health Summit has a motto, it's in the back of your book, which says, building trust for the healthier world. And trust is the most important thing. And I think healthcare workers and healthcare facilities are the most important part of the society during the war and conflict, and we need to protect them. With that, I would like to ask you to applaud our panelists, wonderful people who provided their wisdom. And your good self as a good auditorium and providing us with the good opportunity for discussion and learning together. All the best and enjoy the WHS night tonight. Thank you.